My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Poppy.
And you're listening to the Fix Podcast,
your source for all things implant dentistry. Let's talk about your placement of pterygoids, how deep you go, and how that affects your prosthesis when you have a good shelf, all the way back. And then after that, let's talk a little bit about M versus V configuration. And then when we're finished with that, let's go into the questions that you have for us, and we'll save some of our other questions for the next podcast. And just so you guys know, the audience, we do plan on having Clark on, hopefully, once every month, once every 2 months, and we're going to continue to answer some of these more advanced cases and hopefully make this a continual thing. Because as everyone knows, Clark's a wealth of information. And if you haven't had a chance to go to his course, I definitely would recommend checking that out, because every time, Tyler and I have probably gone, four times. Yeah. And every time we go, it's like, just you pick up new pearls here and there. And you have a great
for the record, I almost went for my birthday. my birthday was this past weekend, and I almost went to the course for that, but my wife had some plans for me, so I had to make the smart decision there. But I was close.
Gotcha. Yeah, we just we had the course this weekend, and it was going to be with Vishy, and he was going to come, and he had to Zoom lecture. Unfortunately, his mother passed away, and so he had to catch a plane and get out of there. But we had Dr. Fayette Williams come in, and
nice.
So if you're familiar with what Fayette does, it very much humbles what we do. Fayette, we may think that we're doing good with teeth in a day, and Fayette is doing jaws in a day.
Jaw, yeah,
and fibula teeth, and so he's a amazing surgeon. He does several days a week in the OR doing microvasculature reconstructions, head and neck, cancer. He's a guy that I work with in Fort Worth, and I have sent him several of our cancer patients. And the pictures that he sends me of these cases are just absolutely incredible. He's doing these free flaps where they're doing these, lateral pec flaps and tunneling them up through the neck, and just all the kind of, crazy stuff. It's interesting. I was showing, he knows about transnasal, but he had never done one, and I was showing him, and he was like, oof. And here's a guy that does lateral neck dissections and dissects down the carotid artery, and he was kind of like, I think maybe the transnasal thing is not something that I want to jump onto. And I just told him, I just said that's so funny, because I would shit my pants if I had to dissect do a lateral neck dissection. So I just said kind of to each his own, right? And so it was just kind of interesting what you're comfortable with. But the cadaver course was really great. It was really amazing. I can't tell you how many transnasals we nailed. We got lots of docs doing transnasals, and it was really cool to have Fayette come in, because he really explained and showed how to advance a buccal fat pad. Here's a guy that is in the face every day, and so the attendees really had a good experience with Dr. Williams. But
nice.
Rolling back to the pterygoids, one of the main problems that I see with clinicians is they're oftentimes not placing them deep enough. And whenever we talk about Patsy, my approach to Patsy is still the same, exactly the same. But I do say that a clinician can do the anterior implants first, and then go back and do the pterygoid. It doesn't necessarily change up your sequence there. But I do feel sometimes if a clinician starts in the pterygoid region, keep an open mind because you may need to go back after you've placed all of your others and deepen your pterygoid. So we can still do Patsy. We can still do the pterygoid first, place it. Just don't put an abutment on. I think that's probably my recommendation is don't put your abutment on your pterygoid. Do the abutment on your pterygoid last. Have your anterior and your middle tilted, placed, and the abutment placed. Because what we all know is for biomechanical success in our arches is that we need the abutment platforms to be all on the same level. And if you're not getting your abutment platforms all on the same level, you're having uneven tissue thickness, uneven prosthetic thickness as well. So just really pay attention to that. I want to get my abutment platform on the pterygoid equal to my middle implant. And so keep an open mind. You may have to deepen your pterygoid to nail that. So that's oftentimes on the pterygoid, I'm placing a 17 or a 30. When I was brand new to this, I placed a straight, and it can still, if you place a straight in the back, you have to seat your prosthesis anterior to posterior because it's not going to make that curvature. The challenge that I ran into the ones that we did in 2017 was the milling angles with a straight abutment were way too steep.
Yeah.
And so we still want to place a 17 or a 30 that really has a very similar path of draw to all of your anterior ones. So that's kind of the other reason of why I think you need your anterior abutments on before your pterygoid is because then you have to also look at our path of draw.
Yeah, that's a really good point, and I think that's a important nuance, and especially like if you're a clinician that kind of lives in this middle world between traditional all-in-4 and Patsy, like let's say you're sort of in that PFAS world where a lot of us are living. If you're not placing zygos, whether or not you get pterygoids doesn't really inform that much of what those front 4 implants are going to look like. And so, I mean, yes, you can say, you know what, Patsy says I got to place the pterygoids first, and that's going to eventually inform whether I'm going to, do an A-frame or whatever with my zygos. But if you're not doing zygos, there's, and even if you are, you can still, and I like your compromise there, place your pterygoid, but don't get married to your final depth of placement. Just get it somewhere where it needs to be, then go place your front 4, get some multis on, and now you can sort of look at that plane along there and then figure out what that final depth is going to be. So you don't necessarily have to have your pterygoid settled before you ever tackle the front 4. That's something that I've done for a long time. In a lot of my cases, my pterygoid multi-units are sitting inferior to where, or superior, depending on how you're looking at it, inferior to the front 4 abutments. And you've given me that feedback on a lot of different cases. So I've been trying to work on that a little bit. And I like what you said there about settling the final depth after those front 4 have already been chosen. Now you can really cater things. So something I'm curious about too, because, we're addressing prosthetic heights of the multi-units in comparison to each other. But what do you think about crestal versus supracrestal versus subcrestal placement for the pterygoids themselves? What are your thought processes on that? Because when I first learned about them, I was being advised to leave them 1 to 2 millimeters supracrestal for access. If I ever had to go back and take one out or something like that, leave it a little bit supracrestal. And I think a lot of people are being taught that. And now what we're seeing a lot of in pterygoid specific implants are tissue collars. So like a 2 millimeter polished collar or even longer. I think Norris has up to like 5 or something like that. I could be totally wrong about that. But you're seeing a lot of polished collar implants that, presumably are supposed to be placed supracrestally. So I'm curious about how you weigh in about that and how you kind of, cater the design of the implant. What is the ideal implant? I'm throwing a lot at you, but can you kind of speak to the crestal aspect of things?
Yeah. So, a polished collar, right? So, why would we want that, right? Maybe for cleansability, we would want a polished collar in, a case that where, maybe there's tissue and not bone. And, we may want a polished collar in a scenario where maybe we expect like the tuberosity bone to recede,
I think
right?
too.
And kind of atrophy.
Yeah.
And my thing with that is, okay, that's all those are good, right? So then at that point, what would we be concerned about, right? On a traditional all-on-X implant, we'd be concerned about, okay, well, that stuff would lead to recession, thread exposure, right? That's kind of that longer term, triad complication.
Yeah.
Well, okay, I've done 1,000 pterygoid implants. I haven't seen recession on one.
Yeah.
Pretty good.
I think that the reason that these implant companies are doing a polished collar is because they're trying to make an implant for the masses, maybe people who haven't placed 1,000 of them, and these doctors are having issues with the tissue around that implant. And what I do, and I learned this at your course, is every time I place a pterygoid implant, I am back there thinning that thick tuberosity tissue out because I want my prosthetic to sit all in one plane, kind of like you've talked about. And if you stick that implant and it's 2 millimeters supracrestal with a polished collar on it, the reason that I think people are doing that is because they have that really thick tissue back there and they have a difficult time putting the prosthetic on, pushing through, like 6 to 8 millimeters of keratinized tissue. And the solution to all of those problems, and one that's better for the prosthetic, is to just grab that tissue with a tissue forceps, take a new scalpel blade, just thin that tissue out, that connective tissue there, and all of your tissue is going to lay much better around that pterygoid implant. And I think the smartest way to do it is to place it, at the level of the crest, or maybe a little bit subcrestal, depending on where your implant placements are on the anterior fork.
Yeah, I would 100% agree with that. Yeah, I just think there's some laziness there, and then it's just kind of having a different mindset, right? Because when I teach people at the Texas Implant Institute courses, a lot of times their eyes just get huge, and they're like, and you can just tell you're like, they're not going to do that in the clinic. they don't want to do that. But I'm like, the second that their eyes are huge and they're like, there's going to be bleeders and all this sort of stuff. But then when you show them and then you just lay that thin tissue over it and you just feel how silky and smooth and all the restorative space that you have, then they're like, okay, I get this, right? So it's worth the extra 10 minutes because it does take, it does add to some surgical time, but it's not like it's 20 minutes. It's a 10-minute add. But I think it results in a beefier temporary, less fractures, right? So that's just going to save you more chair time. But I also, to that point, I just want to complete the thought, or I'm going to forget it. But I would say it doesn't for the pterygoid. It does not have to be subcrestal. Because we're not going to gain anything. We're not going to get bone to grow over that abutment in the tuberosity region. So subcrestal's fine, equicrestal's fine. Just make sure that it aligns with the abutment. But my other point is, if you were to give me the Norris and say, like I would have no way of knowing what implant to select because of that polished collar. You know what I mean? Like, how do you when you drill? What are your drills drilling to? Right? Like is it just the implant depth? Does it have the polished collar on that? How then do you choose your implant depth? So to me, it adds more complexity to just the execution.
No, I agree. Quick point too. The thinning the tissue. Something else that I think that is really powerful, and I don't know if I think I maybe got part of it at your course because it was back when Rick Klein was there talking about thinning the tissue, and Something that I do a lot now, and I think it helps me quite a bit, is when people are doing restorative space calculations, I feel like there's not a lot of providers that factor in the thickness of the tissue in the restorative space. So what I mean by that is, you get patients that do a high smile line, and you're measuring from that tooth to the top of the lip, maybe adding 2 millimeters down there, using that to do your reduction. Or, I know, Clark, you like to do your multi-unit guide, or you had
4.
Okay. But you can gain quite a bit of restorative space too, just by thinning. Some patients have super thick tissue in that anterior region as well. And if you thin that tissue out, you can sometimes save a couple millimeters of bone, having to reduce that bone because you can reduce down that tissue. I don't know if that's something you do too, Clark, but I find that, when you pull that palatal tissue forward, it can be 3-4 millimeters thick. And if you thin that out a little bit, it gives you a little more restorative space there as well.
Well, it's not only an advantage in gaining restorative space, but it is an advantage in being able to buccalize our palatal mucosa. Because once you thin that, and I'm not thinning this just in the kind of more of like the superior portion of the palate. I'm thinning it, 10 millimeters deep, right? So that way it's not just on the top portion, but it's also in that beefy kind of vertical portion of the palate as well, so that as we pull, everything is being buccalized. And so we're getting buccalized, keratinized gingiva from the palate, and just really avoiding any type of periodontal insults with having just the thickest and hardest tissue around our multis. And one little trick is change out your 15 blade. I'll see providers still struggling. I'm like, that blade's dull. Just change it out. And some days my assistants they'll bet on how many 15 blades we use in an arch, and it's very variable.
Depends on the thickness of the tissue.
Yeah.
How much trimming?
Yeah, but don't be afraid. Oftentimes I'll use one brand new 15 for one side of the palate and a brand new 15 for the other.
Yeah, they're cheap.
So they're cheap, and one of the challenges with thinning the palate is if you perf it, right? But that's kind of why you use those tissue forceps, and you just go straight down the middle. You allow that metal to guide you to where you're not going to perf, and you need to be ready to tie off some bleeders, right? I think Tyler, you wanted to talk about some bleeding things.
Yeah.
You can use a bovie or electric artery. I think a bovie works better than electric artery, but if you don't have either of those, I tell you what, just tying off a bleeder is way better than either of those, because you can just loop it. And I do not control bleeding with epi, because they're going to bleed at home. And so control your bleeding without epinephrine. You can utilize epinephrine, say if you're doing an analog conversion process, just to kind of make sure that you can reduce your heme, your ooze and your bleed. That's just kind of oozing. That's just natural oozing. You can use epinephrine to control natural oozing. But I would not really use epinephrine to control the bleed, because it'll just rebound. So, oftentimes it's as simple as just you have to find your bleeder, and you go distal to it, or you go, posterior to it, and then anterior to it, and then you're just going to tie a knot. And I've had times where I'll tie a knot and I'll cut off the tail, and I'll tell the assistant, don't cut it. We're going to wrap several more times around there, and then suture that down. I've had some bleeds where we've wrapped them 2 to 3 times. Typically, I find that the electrosurge works really well for kind of the more as we're getting distal to those arterioles, right? So kind of more in the upper coronal aspect of the palatal flap, the electrosurge works well there. But if you're getting a bleed that's a little closer down to the greater palatine, that's going to need to require a suture. And one of the big things that I've done in the past 2 years has been switch over to utilize tuochromic gut suture.
Yeah.
And it is so much stronger, and your needle is a lot longer, and so you can really get to some of these deeper areas, and you can pull tighter, and you can cinch these things down because you have a stronger rope.
I also use tuo.
Yeah, that's something you definitely converted me and Soren as well on. Is it's tuochromic for every full arch case. It's fantastic. You can really get aggressive with it.
It's and it just makes sure suturing so much easier and better, and make sure you're soaking your sutures, right? All my assistants know, we have a bowl of water, sterile water, and the start of the case, that chromic suture's soaking, and by the time we're ready to suture, it is just silk, and it just rolls really good.
Yeah, definitely. And I know, before we start wrapping things up here, so I know we wanted to talk about configuration. So we wanted to talk about, inverted V's, M configurations, placing your anteriors parallel, pros and cons. I mean, you see a lot of different things now. There's some surgical advantages to different configurations. There are prosthetic advantages to different ones. At this point in your career, Clark, what has become sort of your standard configuration that you will approach your upper full arch cases with?
Yeah. So, I mean, I can say definitively, without a doubt, I am no longer, going to be doing an axial anterior implant. So those are gone. I want to be angling all of my implants, and I do it for a prosthetic reason, right? I do it because I now have infinite timing options because I'm going to place an angled abutment, right? So if all we do is axillary implants, we only have 2 options to correct our screw channel access. We have a 0, right, which is our straight, or we have a 17, right? I mean, so oftentimes, as we all know, sometimes we don't like the straight, and then sometimes the 17 is too palatal or too buccal, right?
Yeah.
But if we angle our abutments, then I can change the timing 2 to 3 degrees and then place an angled abutment on there. So all angled, right? So that knocks out axial. And my preference, every time that we can, and I actually had a case yesterday, that I could not do. It was just, there was a very large infection on number 9, right? So, but just in general, every case I can, I am going nasal crest. So I want to do the V configuration on every implant case out there. Okay. I prefer the V configuration over the M, right? So M is when the anterior implant is going into the lateral nasal. That to me, the trouble that you get into is now you're kind of having to stack your apical tips of your implants.
It's a bunk bed now.
And if you don't have a lot of bone volume there, then you're going to wind up blocking your posterior implant out. And that's what Patsy teaches us, because then we can just roll in and do a posterior zygo, no big deal. But if you're not ready to just on the fly switch over to do a zygo, then you're going to have some trouble. So if you do the M configuration, you are likely going to block yourself out on the posterior tilted. So I prefer V on everybody. And guess what? Let's say you have a failure of your posterior implant. Well, now you still have tons more room to replace that posterior implant, right? Or your middle implant, we'll call it, because you haven't blocked yourself out. The only times that you cannot typically do a nasal crest is when you have a very large apical infection of your central incisors. And so I had a case yesterday that was very, very much the case. I nailed one nasal crest, and then the other one I actually did an axial. It was literally my only option. It was a resorbed case. My posterior Patsy implant was going to block me out. And so at that point, what's the harm in an axial implant, right? Like I would not choose, for this area on the patient's left side where I could not do a nasal crest, I did lateral nasal, and then I'm going to block myself out and then have to do a zygo, right? Like, the best zygo is the one you haven't done, and damn sure an axial implant is going to be way better than having to do a zygo. So, just a little bit of that shucking and jiving. It's just that's a 1% one-off case, so don't think anything into it. But for sure, nasal crest. To me, how I approach every case, we're doing nasal crest every time that we can.
So
V configuration.
So we're all pro V. Establish that. So when you're aiming for the same spot with both these implants, are you crossing swords? How are you making sure that you're not interfering with each other? Are they, what's your approach for that inverted V, just surgically speaking?
So, I place these exactly the same every time, right? So my number 7 implant is going to be anterior to my number 10. So my number 10 is going to be deep, is going to be posterior to that. So I'm actually going to angle that, much further posterior than my number 7 implant. And that way you always account for it, right? If you do the same thing every time, it just gets into muscle memory. Whereas if you kind of futz around and you're not organized, you may do where you angled them both to the same apical end.
Yeah.
And that's when you wind up, okay, well, one's going to be a 13 and one's going to be a 10, So my ideal, so I like to stack them. I like to have them cross at the nasal crest, and I prefer to do 13s versus maybe try to have the apical osteotomy converge, and then you're doing 11.5s on either.
Right.
So I stack mine in the nose.
So if we're trying to get some symmetry there, you're saying, I think you said your 7 is going to be anterior to your 10. How is the timing going to be different on that? How is that? How are you trying to get? How do you get them symmetrical if you're aiming for different things?
They're still, where the abutments are, you won't know. Typically on my number 10, right? It's kind of like your pterygoid, right? So it not only has a medial angle, right? Because we're aiming medially to the crest. So that's what I would say. I would say the number 7 has one angle, and it's a medial angle. Whereas number 10, not only does it have a medial angle, but it has a deep, and a posterior tilted angle.
You're tilting it anterior forward.
So often,
the crest of the implant.
So, I just go by the tip, right? So I want the apical tip to be deep or posterior to my apical tip of number 7. So oftentimes, the number 7 implant may utilize a 17-degree abutment, and the number 10 implant may need to utilize a 30 because I'm aiming at 30 degrees posterior.
Okay, so that answers what I was getting at. Okay, so sometimes it's going to be a different abutment to account for that different. Okay, yeah, got it.
Yep.
Okay. Typically, what's your medial angle?
But again,
is it a little bit less than your tilted? Is it pretty similar to your tilted?
Yeah, it's typically nasal crests are always less, but there's a little bit of variability in where we wind up going based on. I always look for just a concept of what I call bone shields, and I want to I want to use my pilot drill in the anterior, and I want to find the area of the most dense bone, the most amount of bone, and typically I am going to place my pilot drill in the medial portion of the number 7 socket, right? Like I don't necessarily want to place it in the distal portion of that socket. I want my coronal portion of my implant to have lots of interproximal bone between 8 and 9, and that is going to help fight off lots of stuff down the road, right? Like so our options are, we can choose buccal bone, right? The immediate buccal bone of number 8. We could choose the immediate buccal bone of number 7. I don't choose either of those. I wanna go within the interproximal bone of number 7. And so that can be a little bit variability based on arch form, if they had ortho or if they didn't have ortho. So sometimes we may be more at like a 17 degree angle to midline. Sometimes it may be a more of a 30 degree. So it's definitely more variable, and it also depends on the height of your subnasal bone, and also the just the anatomy of the nasal floor. Sometimes some people have a very nice wide subnasal floor. Sometimes it's a little more constricted, and so all of that kind of changes things. But again, we're aiming to the nasal crest, which is right underneath that vomer bone. But that vomer bone's further back.
It's way back there. Yeah.
Not way back there, but it starts, posterior to the incisive canal.
Mm-hmm. Mm-hmm. Okay, so you heard it here, folks. The inverted V, like that's the modality now. We're moving on from axial placement. Shame on you if you do it. I did it today twice.
What about the
mandible? Yeah, moving forward.
Are you doing a V in the mandible every time?
Same thing. We prefer a V. That angle on the anteriors is less, so I would say it ranges from 20 to 10. But oftentimes we're putting a 17
right?
degree
If your tilted fails, you got another good chunk of bone that you can move that forward one slot, and again you can change your timing a little bit better with multiple areas to change that timing. Correct.
Exactly. What about you guys? Are you guys
I'm
doing
typically doing
V's or axial
on my cases still, but I 100% agree with everything you're saying. Patients that I'll do inverted V on are patients with really pneumatized sinuses that I want to make sure that I have enough room to place another implant if I need to, if I have a failed tilted implant. But typically I'm doing axial, but I probably will start doing more V's. I think it's smart. I don't think there's a reason not to, and I agree with all your points for sure.
Yeah,
awesome.
For sure. Yeah, and I mean, I love the prosthetic flexibility of it. I always get this. You mentioned at the very beginning of this conversation is when you're placing axial, you usually only have like 2 options, and you're going to try the straight, and then you realize maybe you're a little bit more buckled than you had initially intended to be. Now you're going to be like, okay, I guess I'll put a 17 on there, and then you end up more palatal than you really wanted to be. And so it's like there's not really a great world in between. So by doing the inverted V, it gives you all the flexibility in the world to figure out exactly how that needs to be timed. I am curious, when you're timing those implants, are you usually I'm always looking at the dot for my timing, right? Is that usually going to be pointing towards the midline with your inverted V configuration? Is that very similar to how you're timing your middle tilted implants? What are you referencing as you're timing your implant usually?
Well, I think in the inverted V, the most important consideration is implant depth. And
we got to talk about this. Yeah.
Because you're actually going to place, especially your number 10 implant, or whichever implant goes deep to the other one. I measure my subcrestal desired depth, which is 1 millimeter subcrestal. Measure that on the shallowest part. Well, on the nasal crest, that's going to be not on the buccal, but on the palatal side, right?
Mm-hmm.
So your palatal wall, you're going to get your implant 1 millimeter subcrestal as measured on the palate, but as measured on the buccal may be 2, 3 on the buccal. So these implants are going to feel deeper. So you're going to have to get in the habit of measuring your abutment depth on the palate. It's the same concept. It's as we do on our posterior tilted. It just feels very, very odd to place one so deep, and so clinicians need to take that into account when you're measuring your depth. And again, measure your depth on your drills, and we know exactly the depth to do because we've done a subnasal lift, and so we are able to feel our drills. Sometimes if we have a wider nasal crest, we often, sometimes we can't, but we'll take an X-ray to account for that. And whenever you're doing your measurements with whatever method you're doing your measurement, make sure that you are placing your implant to the desired subcrestal depth. Sorry, you're taking your drill. You want your drill to be as deep as your desired subcrestal final implant depth, and so that way there's not any variability. But as far as timing goes, I always say that the dot, right? Yes, for all of our implants, I start checking the timing in our screw access channel by having the dot be pointing to midline. But I always say that the teeth win, and so oftentimes the dot will help get us in the ballpark.
Yeah, right.
But always be double checking with your MUA guide, and in your posterior implants, you can check with the contralateral arch. The only implants that we cannot check to the contralateral arch are the maxillary anterior implants. We have to use the MUA guide and know where the final desired position of the teeth is going to be, and that's what gets us the right spot.
Yeah, and I'm curious
another reason why I do not like palatal fiducial markers.
Oh yeah, because you're not going to have a reference for it, or I mean, you could, but you'd have to have like a really big recess.
You have to have a window.
Yeah,
and I do big flaps, right? I'm a big proponent of this, and so by the time I put an MUA guide on that has a fiducial relief, right?
Yeah.
Well. Now I've already disturbed all that tissue, and it's kind of swollen, and there's some blood in there. So then I really question the accuracy of that. So I know that you guys do a digital method without fiducials.
Yeah, correct.
Yeah, and so it just makes it so much simpler.
Oh my God. Yeah, no, I still use fiducials sometimes for like a single upper or something like that. And I suppose that, you probably could design like a multi-unit, an MUA guide that would sort of allow you to actually guide the fiducial placement. So you could, place it even with teeth on, and maybe it's like tooth borne or something, and it has some recesses in it. So you very specifically place fiduciary markers, or not fiduciary, fiducial markers in specific spots, so that when you do get the teeth out, you could then put it on the MUA guide and it would fit just over where those fiducial markers are. So you don't have this like massive window anymore. It's like pre-planned. But this is getting like way. I mean, I don't like fiducials at all, so I'm not going to go through that. But yeah, we do a denture wash method, and it's fantastic for that. So we can really, we can use multi-unit guides and figure out where things need to be. One thing I wanted to make sure we address too, though, and this is brought up by I think Adil Khan mentioned this one. Yeah, he did. So details on the multi-unit abutment height. So you had talked about, where we're placing our implants in relation to the crest. What is the height of the multi-unit that we're placing? And the biologic width that gets established there. And there's some nuances that you've talked about in the group that I've never really obviously I've heard of these things, but I've never heard of them really talked about specifically in the context of multi-unit abutment placement. And I feel like this is like a really important nuance that we're just kind of glossing over. And if you look at, posts that people make on Instagram of their arches and that you show the multi-unit and stuff, there is so much variability in terms of the heights that people are choosing. And, is it with respect to tissue? Is it with respect to the implant placement? I really liked how you talked about the establishment of biological width with regards to your multi-unit abutment height selection. So could you speak to that a little bit?
Yeah, I think that many clinicians try to establish biologic width at the time of surgery. And I think that is false. I think they are missing out on the fact that by simply raising a flap, we are going to have some bone resorption. They are not taking in to the fact the bone resorption process. So, oftentimes what I see is clinicians will be placing subcrestal depth to 1 millimeter, and they will then choose a 2.5 millimeter multi-unit abutment.
Tall.
And yes, tall. And that is incorrect. If you have a multi-unit, if you have your implant that is 2 millimeters subcrestal, then you should use a 2 millimeter height multi-unit abutment. If your implant is 1 millimeter subcrestal, you should choose a 1.5 millimeter multi-unit abutment. And so that's where I start harping on clinicians, is because they did 1 millimeter subcrestal and they used a 2.5 millimeter multi-unit, and it is too tall. And so obviously we're losing 1 millimeter of restorative space just off the bat. And now, on occasion I get patients, they complain about the abutment showing, and it's obviously it's not the implant, and on occasion, it's practically unavoidable in many cases. And you're going to overly pronounce that if you're using taller multis.
Yeah.
So we want, for full arch, biologic width is 1.75 to 2 millimeters. That is the appropriate biologic width. And so I then account for 1 millimeter of post-surgical, that is the appropriate biologic width. And so I then account 0.75 millimeters supracrestal. So that after crestal, we then have establishment of biologic width and loss of roughly 1 millimeters of that bone. 3 months goes by. We then have establishment of biologic width. Right. If your abutments are too proud, too tall, oftentimes what we see when the final prosthetic is made is flanges, right? And so, that leads clinicians to have to hide multis with flanges. And so, if we all think about it from an emergence profile standpoint, the more emergence profile we have, the better, right? So as if we lower our prosthetic margin, then we're able to get a much better emergence profile. And so that's what I am doing with a 1.5. Now, that's not to say that I don't use 2.5s. In fact, I'll use maybe three 2.5s a week. But that's just because for whatever reason, maybe I wanted a couple extra turns, maybe I needed an extra millimeter of stability.
Yeah.
And I didn't feel like mowing a millimeter of bone down, to kind of to make it all flow. And so then I'll just grab a 2.5/17 or a 2.5/30, and it works out great. But again, all of my abutment margins
on all my cases
are all on the same platform.
just to make sure.
That's
just
solid. That's
1
solid.
millimeter. Now, when you're placing your tilted, is your 1 millimeter subcrestal
Yeah.
at the mesial aspect? Okay. Yeah.
Yes.
Mm-hmm.
Yep. And again, on the nasal crest, it's on the palatal.
Yeah. Yeah.
So, and then what you're going to find is when you finalize your cases, you're going to see just beautiful, flat tissue.
Yeah. Yeah. I mean, it's these kind of, nuances that I think can, really make full arch a whole lot more predictable, even when you're doing it at volume. And there's so many little things that are more predictable, even when you're doing it in the post-ops with patients. And it's like minute details. You kind of just write it off as like, oh, these things just happen. Like sometimes patients just have issues with this or that. Like very recently, I had a patient who, all of his implants felt great except for like one particular spot that's been giving him all these issues. It just feels throbbing. It's been hurting. We've taken follow-up X-rays on it. There was no effect. It just feels throbbing. It's been off, and I look, and it's all around that multi-unit. It's just like it's inflamed. It's got like it's not purulence, but you can tell there's a little exudate. And I go and look at the X-ray. I look back at it, and I placed the multi-unit too close to the bone. I had actually impinged on the bone, and so now this pain that he's feeling is he's reestablishing biological width. I forced that to happen because I didn't pay enough attention. I was rushing. I crushed the bone with the multi-unit, and now he's or anything. Then I take his bridge. Now I have the answer as to why that was happening, and or anything. Then I take his bridge happen, and maybe it'll resolve on its own. So these little things, like these very small nuances during surgery, really should it just feels throbbing. It's been
Well, I wouldn't replace the multi. You could take it off. Now, everybody, all my staff knows, like, we don't touch implants until they're fully integrated, right? Because the second you go back a abutment off, you never know what's going to happen, right? And especially these neodent abutments, they can be so difficult to remove because they cold well on there so good, and it's super frustrating, right? Like trying to get a cold welded Grand Morse abutment off your implant.
Yeah.
But I will take that challenge all day long because I know that is taking the force off of the abutment screw, right? I know that we are locking that in, and now we're mitigating abutment screw loosening. Some of these other companies, when you just kind of get them halfway loose, I mean, like the Nobel stuff, the second you get that abutment loose, it's wobbling, ready to go. But what I may just recommend is, why don't you just give him 100 milligrams of doxycycline, and I've begun to use that For anybody that just kind of has like some atypical gingival stuff, right? Like if there's some foots going on in the gingiva, 100 milligrams of doxycycline, or if you have a patient who is maybe they're slow to heal, if they come back, they're still hurting at 2 weeks, that sort of thing.
Yeah.
You know, sometimes you can get some postoperative palatal necrosis.
Oh, you
and obviously, if and when you have palatal necrosis, you need to remove that dead tissue. It's not going to get any better. You got to get that dead tissue out of there. But then they all get 100 milligrams of doxycycline, and that typically speeds up a lot of the healing.
Is that just a single dose, or what is it?
You give it BID.
Okay.
100 milligrams doxycycline BID, 7 to 10 days. It doesn't do anything on the healing part, other than it just it's a broad spectrum antibiotic that helps. Just if the body is trying to fight off different little bugs that may be impeding your healing, and then now you wipe it away with the doxy, then now the body can just focus on healing.
I like that. No, that's great.
So it's definitely been a nice little thing to give that, and oftentimes, patients just want something, right? There's a psychological deal where they're just looking for you to do something, right?
Yeah.
Saying we can't do anything is not reassuring to the patient.
It's hopeless. Yeah, that's fair.
Now there are cases totally where you can tell your patient, I got you, you're fine. This is not going to turn into an infection. It's too close to surgery. You literally need time, and there's nothing I can give you other than time. That also is assuring, when they know that it's just a time thing, when you're prescribing time.
Yeah, that's solid. Yeah.
But not being able to say that and just be like, yep, nothing I can. But not being able to say that and to feel you and listen.
That's fair. Yeah, that's fair. Well, Clark, this has really been fantastic. I think we may have gotten through 40% of the outline that I made for us. So we've at least got 2 parts here, and I think that's fantastic. And I think we ought to save a little bit for next time, because I think this is going to be a recurring series. And if not only for the audience, I think it's for Soren and I, because we learn something every time we sit down and talk to you. And there's generally a pearl that we'll carry forward for the rest of our careers just about every time we talk to you. So we certainly appreciate that.
Well, awesome. Yeah. Well, just kind of like I think what did Elon come out, or it was Eric Schmidt came out and said that we've given AI the fullest extent of all human knowledge. There is an extent to mine, so we will reach maximal knowledge that Damon has, so that could come about. So don't be sad when it comes.
Well, I don't think we're at the bottom of your large language model.
Once we hit that,
your chat GPT 6.0 is back to
square one.
That's funny.
Oh,
yeah. Refresher, just like the cadaver refresher. That's all it'll be. Yeah.
Awesome. Well, I really liked our interview with David Zelig. He is a super nice guy, and
I hope that
super enthusiastic. I mean, he was more excited than
enthusiastic
I was.
as he was. I actually left that interview
talk about this stuff. And
I need to be more enthusiastic about these cases, because that guy has been doing this way longer than I have, and he still is 100% shot. Oh.
I know. Just stoked.
Yeah. Just overall super nice guy, and I mean, I took 2 pages of notes just talking with Zelig, and I already know all this stuff. But just kind of the way he talked, and the way he presented, and I think that'll be such a great person to have on, and
Mhm.
really, we should try to get Vishy or even
Yeah.
Juan on, to really talk about medical legal stuff, and like what do guys need to really kind of pay attention to. What are things that they all can benefit from, and I think there's a lot to learn there.
Yeah. No, I agree. I think that's a good wrinkle that we've never even touched on, and we've both talked to Juan before, and I've been trying to get Vishy on here for quite some time, and yeah, I definitely think they can bring some color to that conversation that would be really interesting. So yeah, I think you've given us some great ideas, and we look forward to the next time we get you sat down, and either it'll be conversations with the tribe or conversations with another fantastic leader in full arch. So again, we just really appreciate your time, Clark, and we look forward to next time.
Awesome, guys.
All
Appreciate
right,
y'all.
awesome. Thank
It's
you.
always fun to talk, and y'all keep me thinking, and so it's good.
For sure.